Okay, great. It seems we're right on time to get started. And I do want to be respectful of everyone's time, everyone who has joined us today, as well as our special guest panelists who have carved out time to be able to present for our NHPA members. I also want to thank everyone for joining us who are NHPA members for this really special event that we have for you tonight, titled Caring for Kaiser Permanente's Workforce, Patients and Communities. It is 8:30 p.m. Eastern Time. For those of you joining us on the West Coast, it is 5:30 p.m. We will be going on until about 9:45 tonight, with the last part of it reserved for questions from for our panelists. Next slide. So we do want to touch on some housekeeping things before we even proceed. Please make sure all your microphones are muted, and we highly encourage you to type any questions into the chat box. Do it in real time as a presenter is talking, and if you have a question for them, please highlight it into the chat box. I will make sure to come back to it during our question and answer session at the very end that we have reserved about 15 to 20 minutes for. So my name is Lisa Marie Serrano. I am the Programs Committee Chair for the National Hispanic Pharmacists Association. You may have seen me on the student webinar that we had just about a month ago, and we're excited to be able to bring another one to all of our members. Next slide. I do want to thank you for continuing to move along with our vision to be the lead pharmacy organization for improving the health of Hispanic populations in the United States. And these webinar series are really to also move along our mission, really to help and to empower Hispanic pharmacists such as you and those who are training to become pharmacists and other members to improve the health of Hispanic populations in collaboration with the public and private sector partners. Next slide. Just to remind you of all those key stakeholders who are helping to push along our mission and vision, we have this wonderful team of individuals who sit on our board of directors. Our president, Maria Hearns Rivas, which you'll see a little bit later today, and of course, everyone else that helps to build this foundation. Next slide. We also want to thank our corporate advisory committees for always having our support and really helping to push all of our initiatives forward. So thank you to them. So without further ado, I would like to briefly introduce every presenter that we have tonight. We have a great presentation ready for all of you. We have very exciting speakers and key stakeholders within the Kaiser Permanente workforce here to share their information with you. The first one up, we have Dr. Alfonso Becerra, who is the pharmacy director from Northern California. Next up, and I'm not featured here, but we do have her on the screen, is Nisha Patel, who is the National Pharmacy Operations HR Project Manager. Next up will be Michelle Linares, who is the KPLA Northern California co-chair, and our president, but gonna have a different hat on tonight, Dr. Maria Hearns Rivas, who is a phase care manager and is an ambulatory care clinical pharmacist for Kaiser Permanente. And finally, but not least, is one of our Kaiser Permanente's PGY1 resident pharmacists, Dr. Stephanie Golick. And then you'll wrap up with me at the very end to touch on those questions and answers that you've had throughout the presentation. Next slide. Okay, so first up, we have Dr. Alfonso Becerra presenting on Practice What You Believe. Dr. Becerra.
Great, thank you. Can everyone hear me okay? All right, great. So thank you again. Thank you for having me. As mentioned, I'm Alfonso Becerra, and for those of you that know Spanish, yes, I got a lot of flack for that as a kid, my last name. For those of you that don't know Spanish, Becerra has a meaning, in Spanish, becerro means calf. Think of a calf, cattle calf, Becerra being the female calf. So not a common name, got a lot of flack as a kid. Now I've learned to enjoy it and share it in its uniqueness. So yeah, go ahead and go to the next slide. So thank you again for having me and allowing me to kind of share along with my colleagues from Kaiser Permanente what we do in our organization. Large organization, widely known on the West Coast and in certain pockets of the country, which I'll show you here in a second. You'll see it, in terms of working, what we believe in and what our core beliefs are in terms of what we do in health. And I'm sure you'll be able to appreciate that. So in terms of what we believe, and you'll see four quick pictures here. We believe that life and liberty and the pursuit of happiness require total health, and that's part of it. And it includes access to high quality health care for all. That's core to our belief. Also, we believe that total health is more than a freedom from physical affliction. It's about total mind, body, and spirit in terms of your health. We also believe that healthcare must be affordable for all. This is key, and this is key since we started our organization. And the last part, we believe in a healthy and engaged life with good beginnings and dignified endings. And you'll hear this, you as pharmacy students will hear this term, dignified endings. I think healthcare is realizing that you start from when you're born all the way to your decisions of end of life in terms of how you end life and how there's different choices there. It's all part of healthcare. So go ahead and go to the next slide. So Kaiser Permanente, funny name also, founded in 1945. We are the nation's largest not-for-profit healthcare organization. And these are 2018 numbers, so these have gone up a bit, but we've got over 12.2 million members. You'll see our biggest populations are mostly in California. So Northern California makes up over 4.3 million, Southern Cal is 4.5, and then we're interspersed between Oregon, Washington, Colorado, Hawaii, Georgia, and for those of you in the Mid-Atlantic states, we're there also. So Virginia, Maryland, DC. You'll see us making inroads there also. Good, go to the next slide. So our medical care program, you'll hear this about us a lot. We're integrated, meaning we have both our medical care with our physicians and then everything else. And the quickest way to describe this, we're all in one. So as you go into one of our facilities, you're being seen by physicians. You go downstairs and get labs done in our own lab. You'll go to the pharmacy to pick up your medications. You'll get your x-rays. You'll see your nutritionist. You'll see your therapist. It's all in one healthcare, all involved. And that's core to our business and how we started, and we think it's core to our success. We practice a lot of preventative medicine. So it's not just treating you when you're sick, but trying to prevent you from getting there, getting sick, and all the steps and what you can do before getting sick. And we practice a lot of evidence-based medicine, meaning we do a lot of research on what is the proper way to treat patients, to provide therapy, and going off real evidence-based, not of what's the newest and the newest therapy out there. We really make sure we do our research on the back end. And again, as I mentioned, we own and operate our own facilities. A lot going on this slide. I won't read through the whole thing, but it just gives you a snapshot of kind of what we're looking at here, right? Close to 23,000 physicians, over 12 million members. It says 199 million mobile visits. It's a lot more now since the start of COVID. We're transforming mental health, and then it gives you a lot of different options. One place I do want to point out is we're usually at the top in terms of best place to work, or usually within the top 10. So it is a great place to work. Go ahead and go to the next slide. So a snapshot of Northern California. So when you look at these numbers, as I mentioned, we're spread out. If you want to think of how we are spread across the country, you double, sometimes triple these numbers, and you'll get a snapshot of what we are nationwide. So we're the leader in providing pharmacy care service across the nation. You can see we're about 32 million prescriptions filled. And we like to point out that would take around 218 CVS pharmacies to fill the same amount. We're about 24 million doses administered, and this is an inpatient. In a minute here, we'll talk about the difference between outpatient, inpatient, and clinical services and our different service lines. In terms of oncology, our chemo pharmacies is 385 doses for that year. So it's a lot of medication. As you know, a lot of medication is very expensive. So we see At the time, it was 3.2 billion in annual drug expenses, and then another 800 million of the cost of actually dispensing, providing these medications. For Northern Cal, again, about 176 different pharmacy sites. That includes outpatient pharmacies, inpatient pharmacies, clinics where we administer, infusion centers, call centers, our central fill, our mail order pharmacy, and our home infusion pharmacies. So we run the gambit of all pharmacy services in terms of what we provide. About 5,400 pharmacy staff members just in Northern Cal, and that means that's on their 58,000 daily member interactions. Our department, our pharmacy department, has the most contact on patients on a day-to-day basis, more than any other department in our organization. Next slide. Some more volumes, because I'm sure you guys like to hear more numbers here, but we talked about member visits, encounters, the amount we prescribe, our lab orders. We are a high volume organization. But with that said, even though we're high volume, we make sure we provide world-class service. Go ahead and go to the next slide. So some more kudos on what we do. We have our mail order pharmacy, which is always rated very high with J.D. Powers. And for each of the past 7 years, we've earned different awards in terms of our quality, our Pharmacy Quality Alliance Excellence. The quality award, one of many. Again, our service in terms of J.D. Powers, what we receive in our pharmacies. We've received a number of quality awards, and these are called our VOES Award for Quality. Actually, it was involved in one last year, which involved our skilled nursing facilities and how our pharmacists can help with medication reconciliation as patients are transferred from a hospital to a skilled nursing facility to home. And then we also won a best practice with ASHP last year on that same project. So we're usually there at the major conferences in terms of providing our best practices. Okay, next slide. So a little bit foray into the future, if you want to look into the looking glass in terms of what it's looking like for healthcare in general. So I'll start from the top. You know, there's major challenges and changes in demographics and workforce changes, right? A lot of our folks are going to Medicare. The workforce is looking different. Demographics are looking different. So as I state either these benefits or challenges, think about where you can fit in healthcare and where you can find your niche in healthcare and assist. Number two, our patients, our members everyone pays a lot of money for healthcare, and they want value, right? They want service. So everything is turning to customer-centric focus, right? What does the patient want? And what we say now, we used to say, what does the patient want? Now we say, where does the patient want to be served? So think about that also in terms of how healthcare is moving forward. It's now, where does the patient, we used to think, you go and see your doctor, and if you get really sick, you go into the hospital. But now we're kind of flipping and say, a lot of patients, especially with COVID, now they want to be treated at home. You have video visits. I want to speak to my pharmacist on the phone or a video visit. I don't necessarily have to go in the hospital. Some of these, I can get a procedure and be home real quick and be treated or followed up at home with many different parts in terms of pharmacy. Big data. As you guys will know, our organization has a lot of data on our members, and we use that to tailor their care. So that's important with any healthcare organization. I think they're all trying to do that. There's a lot of consolidation, and there's new disruptors, players coming into healthcare. We call that Apple Health. You'll hear about Amazon, who's now also getting into the pharmacy business. So I think in terms of a healthcare organization, you need to be ready for those new players coming in to disrupt. What can we learn from them? They're trying to learn from us, but there may be things where they can improve. There's things we can learn from them. The expanding role of government, so it's under by 2027, 47% will receive coverage through Medicare and Medicaid. Not to be a little political here, but when you hear about socialized medicine, are we gonna get there or not? We're halfway there. Let's admit it, right? Half the country is on Medicare and Medicaid. So what are we going to do to make it work better, to make it succeed? And then back to the affordability. To make it succeed, we got to make it affordable. Right? So in terms of pharmacists and how they have an increased role in healthcare, well, there's not enough primary care providers, MDs, to go around the country, right? There's got a lot of specialists, but not enough providers. So this is where we as pharmacists fit in, right? And you'll see this a lot also from nursing in terms of, years ago when there wasn't enough providers, there was this big switch to nurse practitioners, right? Because the nursing industry took into account, well, there's a niche, there's a need, we can fit in. And back then, there was a field within pharmacy that, we missed the important piece where we could have filled in there, but now it's coming across again. Where can we do as pharmacists, right? So when you think of pharmacy or yourselves that are in pharmacy school, it's not just the dispensing pharmacist. There's a whole different array of different roles in pharmacy you can do in terms of providing care. And this just describes them a bit. So you'll hear about medication adherence a lot. That's a big piece. You'll hear the term hyperpolypharmacy. What that is basically grandma's on a lot of medications, a whole lot of medications. So the thought is, every time they go to the doctor, they get a new prescription. Well, let's flip that. Let's say, do they really need to be on all those medications? Is it time to reassess and see, are they taking them? If they're not, what can we take away to help them stick to their medication? MedRec in our clinical performance, I'll talk to you a bit about that, and an integration with the healthcare delivery. And also the services impacted our outcomes. So any service, any pharmacy service, any clinical service you're providing, you really have to show that you're making an impact with these patients. And I think with pharmacy, you will. So go ahead and go to the next slide. So what you really want to know, right? Career paths. All right, let's talk about career paths within Northern California. So our pharmacy practice settings, right? So, if you talk to your family, you think, oh, what do you want to do? I want to be a pharmacist. What do they think about? They think about the older pharmacists dispensing tablets in like an old pharmacies, right? That's totally flipped, right? That's just one piece of pharmacy. You've got practice settings in the hospital or inpatient pharmacy. These are, as you know, our outpatient clinic, AM care, home infusion, and administrative. Go ahead and go to the next slide. So our outpatient pharmacy setting, within Kaiser, our outpatient pharmacy setting is our quote unquote retail setting. So we dispense outpatient prescriptions from our own pharmacies. We work on one national pharmacy system, it's computerized physician order entry, so no more prescriptions, docs don't write prescriptions anymore, they send everything to the computer and it goes into the pharmacy. We all have the one electronic medical record, EPIC, hear that. Our outpatient pharmacies and pharmacists are now starting to do clinical work. So as the profession moves away from dispensing and being more clinical, what we're finding ourselves is our outpatient pharmacists, our retail pharmacists, we need to figure out a way to retrain them to be more clinical, to be able to offer more services to our patients, right? And then as we do that, we elevate the other class, technicians who are working with us, elevate them to do more work that maybe the pharmacist did 10, 15 years ago, they can do within their license so we can do more clinical work. So we're trying to elevate the entire profession as we do that. And of course, to do that, we have technology to help with all the other dispensing tasks. Next slide. Our inpatient pharmacy practice. So some of you will be going into that. These are folks who are in the hospital. We've got pharmacists in the NICUs, the neonatal ICU, the ICU, critical care. We have pediatric specialists. We've got pharmacists in our emergency rooms. We've got pharmacists working in our oncology pharmacies and OR and other specialties. So there's specialties within pharmacy that we're putting folks in. And as a pharmacist, you work on things like antibiotic stewardship, aminoglycoside dosing, renal dosing, pain management, and then transition care services. When your patient's in a hospital ready to be discharged, we have a pharmacist to make sure that transition of care happens. You've got the right medications. And if you guys are thinking in terms of career paths, think of that also. When you think about transitions of care, you'll hear about that a lot. That means that when you're moved from, say, the clinic to the ED, to the hospital, to the skilled nursing facility, to home health, at every one of those transitions, there's a possibility that their medications, there may be challenges to your medication, there may be mistakes. So you as a pharmacist are there to keep that safety net and make sure, grandma's on the right medications at every transition. Go to the next slide. Clinical operations. And that's what a lot of folks come to us to work for. So it's what we're well known for. These are our folks, our pharmacy students. Once you're done with pharmacy school, what are you going to do? Most of you are going to go and get residencies, right? So you're going to get residency trained, and then you can work in any of these settings, right? We have drug education coordinators. We used to call these guys are anti-drug reps. So the drug reps would come in and tell the doctor, hey doc, you need to put the patients on these medications. And, you know, of course, they were the most expensive medications and there wasn't much literature at the time. So then our own drug education coordinators would come in right behind them and then educate folks. And now this is, the data shows this, right? This is not, you know, you should kind of anti-detail of whatever information the drug reps would tell the providers. And there being a big, this is a big piece to our overall organization and our work in terms of a drug education coordinator. Because all the new drugs coming out, we really have to assess, right? Do they make sense to use these new ones? Are they really the next best thing? Or are they just something new that's really expensive? And is it really going to provide benefit for the patient? Ambulatory care pharmacist, that's our big army of pharmacists in our clinics where you're actually seeing patients. And a little bit you'll hear from some of the folks that do that work. You're in there seeing patients, you're going over the medications, you're talking to folks, they're coming in to see you. So you're really in that clinical setting in there with the providers to provide that service. Clinical operation managers and ambulatory care supervisors are the folks who manage these folks. And you'll see there all the different services that our clinical operations work in. Next slide. Okay, and then our centralized practice settings. So we have also in our Livermore facility, we have our automated refill. So we have this giant robotic pharmacy with pharmacists, technicians working there. They do our mail order pharmacy. Southern Cal has a similar one, or other areas also do. We have a pharmacy call center. So that basically talks to patients, go over medications with them, or answer any questions for patients. We have pharmacists, technicians, and clerks that work that. We also have a specialty drug pharmacy, which are all the specialty drugs with special restrictions. Those are actually dispensed out of a specialized pharmacy. And so that's our centralized services. And then, of course, we have all the administrative settings, right? So after you've done, you practice in different settings, you say, you know what, I think I've learned what I do, now I want to run the company. So this is where we train you to go up to the management ranks, and you can find different leadership opportunities, both within pharmacy and outside. Right, so this is our management leadership positions, our informatics, professional affairs, IT, QA, analytics. I mean, you basically can find a pharmacist anywhere in our facility that can assist. Next, so I think this is my last slide. So this is part of, and it'll kind of segue into some of the other speakers. You know, in terms of our perspective, right? What we're trying to really figure out what is the best way to provide care to a diverse population, right? So we looked at ourselves, who can really tell us this? Well, guess what? Our workforce is very diverse. One of our Kaiser is probably one of the more diverse workforces organizations out there. So we thought to ourselves, well, and let's work with our own folks and figure out, you know, what works best for people and how to provide this care. And Michelle can talk to you a little bit about what you do with KPLA, but there's different groups in terms of how we can share those best practices and provide the best care. And you'll see that, right? We challenge our own our employees to ask themselves these three questions right around community health. You know, how can we ensure we're providing the basic human needs, personal health, right? And then the mind in terms of what do we do with young folks that are with challenges early in life and how we get through that. Yep.
Okay. Thank you, Dr. Rosetta. That is a fantastic transition, actually. You mentioned that Michelle Linares would be able to tell us a little bit more about KPLA, and that's actually who we're going to go to next. So thank you for that, Michelle.
Great, and thank you, everybody, for being here and for including me in this wonderful panel. So I'm Michelle Linares. I'm a senior manager with our National Office of Equity, Inclusion, and Diversity at Kaiser Permanente, but I'm also the chair of the KP Latinx Association Business Resource Group, or otherwise Employee Resource Group, that we have at Kaiser Permanente. I have a special place in my heart for pharmacists because as I began my career at Kaiser Permanente in 2008, I started as a health educator teaching diabetes classes and worked a lot with ambulatory care pharmacists to look at the continuum of care of our members, especially those who spoke Spanish, and being the only Spanish-speaking health educator or the only Spanish-speaking ambulatory care pharmacist, we we get together and help mostly our members navigate the system and definitely manage their care. So special shout out to our pharmacists and future pharmacists as well. If we can go to the next slide. So I wanted to first just set some context because we are the KP Latinx Association, and we were intentional in changing our name from Latino to Latinx to be more inclusive of our members and the communities that we serve in providing a gender neutral term. So I just wanted to provide a little bit more context on that, and that it really depends on everyone's identity, how they want to name themselves, but our group intentionally changed our name in 2018, again, to continue to be more inclusive within our workforce, care delivery, and communities that we serve. Next slide. So we are one of 10 national business resource groups at Kaiser Permanente. KPLA, among others, have existed since the 90s. And so we serve as cultural brokers, influencers to our organization in various capacities, whether we're identifying an opportunity to advance equity in our care space, or we're identifying affinity groups like NHPA to help our talent source. And pipeline development as well. But we are together, we help our organization elevate these issues and definitely advance equity and social justice, especially during this time. But again, we've existed for almost 30 years, and we've helped our organization bring in more diversity, as Dr. Becerra mentioned, and other aspects as well in the continuum of health equity. Next slide. So a little bit of more context, because where business resource groups live and help activate, I've been throwing the word equity around. This is our strategy actually for Kaiser Permanente framework. So at Kaiser Permanente, we believe equity inclusion for all. Our mission is really to integrate effective practices to help drive this in 3 areas that you see there. I won't read them out loud, but I'll just share a few examples, and you'll definitely get to see it a little bit more when we apply it to the KPLA lens that we have. So we look at equity when we're thinking about our workplace. Are we equitable in how we're hiring and how we're retaining or how we're promoting our workforce? We're looking at it in our care delivery space. We look at health equity and inclusive care. Are we providing effective practices? Are we promoting culturally responsive care and linguistic care to our members across Kaiser Permanente service areas? And then we look at our community, where our members and our workforce play. Do we have the right investments? Are we bringing in supplier diverse members, vendors into our organization to help with economic growth as well? So within all of this, we really strive and are really proud that we've been doing this for so many years, since the beginning of Kaiser Permanente for now 75 years. We've been really advancing equity, inclusion, and diversity, and we're lucky to have a national function and strategy around this, so we can continue to provide quality care and definitely have a place for our members and workforce to grow with us as well. And so next slide. Here's our latest commitment to equity. I mentioned a little bit of workforce equity, what we're doing specifically to build more diverse representation and retention and promotion of our workforce, but we're also looking into creating more psychological safe places for our workforce as well. And of course, health equity goes hand in hand to make sure that we are improving the health outcomes and also redesigning, rethinking how our processes look like right now. Are there areas where we need to improve that are perpetrating inequities in how our members are navigating our system? So looking into how to improve that or keeping equity centered in mind as we think about our members' journey within our system is key to health equity overall. We're also doing a lot of investment in the community to address racism and interracial and trauma as well. This has come up recently, as you all can imagine, during a pandemic and civil unrest and social injustices that is happening. That also affects our members and our workplace. So it's very key that we work with organizations, that we fund specific nonprofit organizations that are providing these types of care and support and are partnering with us overall. And of course, the economic opportunity that we are driving funds and money and investments, not only to Black-owned businesses, but to also other underinvested and marginalized communities. So this again has been unannounced, but as mentioned, we've been doing this work for 75 years at Kaiser Permanente, but this is our latest commitment to equity overall. So going back to KPLA and our business resource groups, if we go to the next slide, I want to start off with, here's kind of where KPLA comes into play to help with EID, or Equity, Inclusion, and Diversity, and our latest commitments to equity. Our mission for KPLA is really to help support our Latinx and allies to achieve their full potential at Kaiser Permanente. And we really are a driving force. We're one of the top performing business resource groups, not only to help and serve our Latinx employees and allies, but it's also to think about our intersectionality of what it is to be part of the Latinx community too. So we make sure that we make our members and communities proud to work at Kaiser Permanente and to be part of the community overall. And Northern California is one of the chapters that we have across the company. As Dr. Becerra mentioned, KP exists across the country, mostly on the West Coast, but we do have pockets in Georgia, the Mid-Atlantic states. We don't have a chapter in Hawaii, but that's an opportunity there to expand and ensure that there is representation there as well. Next slide. So here's just a flavor, a little example of how we applied those care delivery, workplace, community pillars with EID in mind. If we focus on the workplace area, and you'll hear a little bit more about Nisha, but we advise and link with our own HR partners for strategic areas of opportunity to source talent. And to help with any linkage of an opportunity, again, that KP can venture to increase representation. Now, we have a diverse workforce representation, yet when it comes to clinical roles, there's still a huge opportunity where we are at the national level or below the national level expectations of how many pharmacists or physicians or nurses we have. So we work really closely with our strategic partners to make sure that we're identifying groups like NHPA to help with talent sourcing. We host community panels as well. Last year, we had Dr. Rivas Hearns join us with other clinicians to ensure that we are also educating and creating awareness through future pharmacists or clinicians within our system or in the community, but also administrators and how we all work together. We think about also our own workforce and our employees by providing culturally responsive leadership development opportunities where, as Dr. Becerra also mentioned, that when you are in a clinical setting or you're a pharmacist yourselves and you're ready to take that next leap into leadership, that there are programs that really speaks to the cultural nuances that are commonly found in the Latinx community or perhaps other cultural groups as well. So we pride ourselves into developing these types of programs and making them available to our own members as well as they continue their journey through leadership development. And there's some examples there. It's very small, but just examples of how we've done that. One thing that I really pride myself into is acknowledging our own bilingual, bicultural employees and providers too. We need to make sure that we are acknowledging folks within our system, and they might be the only, for example, Spanish-speaking pharmacist or physician or team in one certain area. So we make sure that we acknowledge and celebrate their accomplishments that they're doing to provide ultimate care to our members. In the care delivery space, we are, as mentioned, cultural brokers and influence. So we co-design and host educational forums to elevate equitable care practices and continuing education as well. We also are a group of members. Something I did not share, we have about over 3,000 members in Northern California. And so we have a good pool of folks to help us with sometimes user testing on educational materials that some of our partners might be coming, or marketing partners or outreach departments might be doing. So we're a source to kind of test those things out before it goes out. And some of the focus areas that we've done in the past to help around the care delivery space have been cancer care prevention, diabetes, of course, family violence prevention, and mental health and wellness. We just concluded a 2-day virtual summit earlier this month, and that's another example of the power that KPLA and other group members can do to elevate, again, effective practices in care delivery. And last, community. We're doing a lot of work other than volunteering in health fairs or in virtual settings or in school panels, for example. We've been changing our narrative around what does a philanthropist look like. And in the last 3 years, we've been working with the Latino Community Foundation to change that narrative and to also take and harness our own power and funds to be part of a philanthropy group. And so this is not exclusive to KPLA members. It's open to all community members as well, where we're donating either one time or on a monthly basis. And at the end of our cycle, we give to nonprofit organizations that are providing wraparound services for our communities that otherwise wouldn't receive in a traditional pathway of receiving funds. So we pride ourselves in that as well, and that we're taking action with philanthropy and our collective power. And so with that, those are just examples of what it is to be a KPLA member and a leader, and also the work that we're doing around equity, inclusion, and diversity at Kaiser Permanente, and how the power of the people can elevate all of this and ultimately provide the best care for our members and our communities as well. So I don't think I have anything on the next slide, but there's just some contact information there if you'd like to follow us and definitely get a hold of us as well.
Thank you so much, Michelle Linares. We really appreciate that. And your organization, KPLA, really coincides with NHPA and making sure that we're targeting every avenue to ensure that the Hispanic population is being targeted and their healthcare is being improved, looking at the professional, looking at the community, as well as the care and delivery that they're getting. So thank you for that. Next up, we have Dr. Maria Hearns-Rivas, and she'll be presenting to you today. Thank you.
Good afternoon or good evening, everyone. Glad to be here presenting on specifically my clinic at Kaiser Permanente. So I am a phase care manager, an ambulatory care clinical pharmacist. I predominantly care for Spanish-speaking patients with diabetes. They make up about 90% of my panel. And today, what I will be presenting to you on, I will actually be wearing my certified diabetes hat on today. And I'm actually going to explore and dive into a little bit more about what's currently in the literature right now about patients who have diabetes who are of Hispanic background. And then I'm going to sew in there some examples that have risen to the top, some common themes that I frequently see amongst my patients. And so hopefully you can walk away with some better understanding about why there are some of the things that they do. And then hopefully that can better help guide you when you're caring for your very own Hispanic patients who have diabetes, because there's many of them. So we're going to start off with diabetes prevalence amongst Hispanic Latinx community in the US and California. And just 1 second, Vince, you can come back to the slide. Thank you. And as Michelle Linares already explained to you, the term of Latinx in the research literature, it's predominantly seen as Hispanic. Latinx is an up-and-coming term that we are using, so I will interchange between the two. I will also go over and talk about some of the barriers that Hispanic community members are currently facing in terms of achieving their A1C goal. And then I'll talk a little bit about diabetes and cardiovascular complications. And then I'm going to present about some of the findings that are currently in the literature to help increase compliance and adherence. As Dr. Becerra mentioned earlier, adherence being important, and us being pharmacists, it's our bread and butter to improve diabetes outcomes amongst Hispanic and Latinx community members. Next slide, please. All right, so here we go. So across the US, in 2019, the number of Hispanics reached a record 60.6 million, making about 18% of the US population. And also, 22% of Hispanics have diabetes versus 12% whites. Hispanics being a very diverse group within within that category, the subcategory Mexican and those who are of Mexican and Puerto Rico descent, they actually have a higher risk for diabetes. So something to keep in mind depending on which groups are more predominant in your particular areas. Next slide, please. Now, as California, so as I did not mention earlier, I'm a phase care manager in Kaiser Permanente Napa Solano area, which is in Northern California. And so specifically as it relates to California, as of 2015, Latinos make up 39% of the state's population. And it's currently projected that by 2060, Latinos will make up nearly half of all Californians. And then also very important as it relates to diabetes, 36% of young Latinos in California have pre-diabetes versus 29% of young white adults. So as you can imagine, the Latino population, the Latinx population is growing. A lot of Latinx youth has pre-diabetes. So potentially we may have a lot more Hispanic patients who have diabetes, and we're going to need a workforce in order to be able to best provide for them so that they may have good health outcomes. Next slide, please. So in terms of barriers to achieving A1C control, the first one being socioeconomic, it's also very common amongst other underrepresented groups. And then the next one being cultural barriers to achieving A1C goals. Some of the things that frequently come up, some of the themes that come up amongst my patients, one, low socioeconomic status, having to work multiple jobs, a lot of stressors, and then culturally related, a lot of demands from the family. A lot of my patients have a tendency of putting themselves last, familia first. And so that kind of gets in the way of being able to better control for their A1C. Now, perceived barriers, and this is in the literature, perceived barriers to diabetes self-management from the perspective of Hispanic patients, or in this case, participants. One, they had reported suffering from diabetes, difficulties in managing diabetes, and then lack of resources and support. So I'd say that in terms of how they're doing at home and doing the self-management is actually rather difficult. And I oftentimes I find that my patients who have lower support at home, they tend to do worse than those who have better support at home, say from their wife who is purchasing and doing the grocery shopping that's more diabetes friendly. Also, if there is a support of a team of family members at home who will go out and walk with you after dinner, things like that. So it really depends on that. And then in terms of suffering from the diabetes, they oftentimes, even when they get that first diagnosis, they're actually very devastated. And sometimes I have patients who are actually pretty much avoiding the topic. They're in disbelief. Oftentimes they have difficulty in believing that they have the diabetes. It takes them a while to process. And then hopefully eventually they come around. So persistence with this population is very essential. And oftentimes I find a little bit more success if I keep at it. Next slide, please. In terms of now perceived barriers to diabetes self-management from the perspective of the family members. So again, thinking about the Hispanic culture, very family oriented, always keeping lots of family members around. So one of the barriers that the family members had reported in this particular study was that they can provide support, but they lack knowledge. What was interesting to me, and it continues to be a constant theme, is that some of my patients and their family members, they don't realize which food groups are carbohydrates. For whatever reason, most recently, there's this higher theme of, they believe that eating oatmeal for breakfast is very healthy. And so they're eating a lot of oatmeal for breakfast, not realizing that oatmeal is actually a carbohydrate, and, let alone the oatmeal, but the milk too. So doing that very patient-centered, very culturally centered diabetes care, and just, kind of assessing where the patient is and then supplementing information medication, oftentimes they tend to do better. So that's something to keep in mind. Another one is amongst language among limited English proficiency patients. So again, it's more difficult for patients to be able to express how they feel if their provider doesn't speak their same language. I will say though that if you're not a Spanish speaker and you are working with Spanish speaking patients, I highly encourage you to make sure that you're using the translative services that are available. I will say that yes, at the beginning it takes more time, but I will tell you that the payoffs are huge. So I highly encourage that. Next slide, please. I also want to touch base upon another barrier, which is low adherence to hypoglycemic medications. This particular study reported that approximately 72% of Mexican heritage adults demonstrated low adherence to their hypoglycemic regimen, and gender difference exists. So 72%. Yes, I often see high percentage rates of my patients being non-adherent to their medications, and it's oftentimes a reason for their high A1C. So here is our bread and butter as pharmacists, counseling our patients. If we notice that they're not picking up their prescriptions on time, or whatever opportunity you have in terms of reinforcing the importance of a lifelong medication adherence to their diabetes medications and other cardiovascular prevention complications would actually be very helpful as well. So I just wanted to bring this to everyone's attention. I see this all the time. Next slide, please. In terms of diabetes and cardiovascular complications, so this is from the American Heart Association and the American Stroke Association. 2016 update's a little outdated, but here's the information. Among Hispanic adults aged 20 and older, 48.3% of men and 32% of women have cardiovascular disease. Among Hispanics aged 20 and older, 3.5% of men and 1.7% of women have myocardial infarction or heart attacks. Next slide, please. Next slide, there you go. Okay, and then amongst Hispanic adults, 2.8% of men and 2% of women have had a stroke. Projections show that by 2030, an additional 3.4 million people aged 18 and older will have had a stroke, a 20.5% increase in prevalence from 2012, and the highest increase being 29% is projected to be Hispanic men. So something to keep in mind in terms of adherence to medications and counseling points with your patients. Next slide, please. And then also they had this here, and I wanted to share with you all as well. Spanish-speaking Hispanics are less likely to know all stroke symptoms than English-speaking Hispanics, non-Hispanic Blacks, and non-Hispanic whites. Lack of English proficiency is strongly associated with lack of stroke knowledge among Hispanics. So again, being able to communicate with your patients in their language is essential, whether you speak it, whether you're a native language speaker, or you need to use an interpreter, something that's very important. Next slide, please. And then this statement is from the science advisory from the American Heart Association. In this particular report that they have, they're giving this conclusion, which I strongly believe in this, and I wanted to share with you all. Healthcare professionals and researchers need to consider the impact of culture and ethnicity on health behavior and ultimately health outcomes. There is a need to tailor and develop culturally relevant strategies to engage Hispanics in cardiovascular health promotion and cultivate a large workforce of healthcare providers, researchers, and allies with the focused goal of improving cardiovascular health and reducing cardiovascular diseases amongst the US Hispanic population. So this has been their recommendation. And so here we are hoping that we are able to close that gap a little bit more. Next slide, please. Okay, so then in terms of how to increase compliance and adherence to improve diabetes outcomes amongst our Hispanic Latinx population, these are some of the things that have been published. One being, in this particular study, they showed that limited English proficiency Latino patients showed a significant improvement in glycemic control when switched from language discordant to concordant PCPs. This particular study was actually done, I believe, in collaboration if I remember correctly, Oakland Kaiser and also San Francisco General, just across the bay. So they showed it here. I strongly believe that we would probably get these very similar findings if a similar study were to be done amongst pharmacist practitioners caring for Latino patients. Another one being culturally relevant family-based interventions improve diabetes self-management. So again, same thing, just kind of meeting the patient where they are, being able to speak to them in their own terms, in their own language, in order to help them better understand their next best steps for diabetes care. Next slide, please. So with that being said, our Latinx patients need you, all of you. I hope that here you were able to obtain some tools and some tips and tricks to help, hopefully be able to help our patients better care for their diabetes. Thank you.
Thank you so much, Dr. Hearns Rivas. We have actually a lot of questions for you at the end, so get ready to answer all of them. So next up, we have Dr. Stephanie Golick, who is our PGY1 pharmacy resident.
Good evening, everyone. Thank you guys for having me speak tonight. Again, my name is Stephanie Golick, and I'm currently a PGY1 resident at Kaiser Permanente Napa Solano here in Northern California. My cultural background is Hispanic and Latina. My family is both from Mexico and Honduras, with my family roots going all the way back to Spain. I grew up in a very traditional Mexican household where the women were expected to take care of the house and the children while the men were the breadwinners, and there was really no in between, which created quite a bit of strain relationships with my family when I told them that I wanted to wait to have children and get married in order to pursue a career in pharmacy. And even to this day, although my family has been more accepting of the path that I chose and I did get married, I still get the, why don't you have children yet? And aren't you too old to be in school? Lectures from all my family members. And although it was and still is difficult to hear some of those comments, I knew that I wanted to pursue higher education, not only to provide a better future for myself, but to help educate and support other Latinos who wanted to pursue careers in healthcare and let them know that, you know, it's a dream that they can go after and that traditions don't limit you. So after high school, I enrolled in the junior college so I could work and save money. And after about 5 years of prerequisites, I was able to transfer to a 4-year college and, you know, graduate with a bachelor's in biology, the first in my family. So everyone was happy. But during this time, I did work first as a pharmacy clerk and then a technician for CVS and Long's Drugs, if anybody remembers Long's. And what I really enjoyed about the work was being one of the only people in the pharmacy who spoke Spanish. And I didn't realize how much of a need there was for the Latino healthcare workers until I was continually asked to travel to different locations where there was a high population of Spanish-speaking patients just to help translate. And although there was the language line, I think the connection you can make with the patients when you're able to communicate with them in their native language is amazing, and the connection is so much deeper. They were more comfortable asking me questions and more open to recommendations and more open to just talking about their health in general. And so those instances helped me realize that I knew I was making the right decision in pursuing a pharmacy degree, you know, just from that community alone, which was my community. And so I began working for Kaiser Permanente in 2014. And once I started pharmacy school in 2017, I transitioned from an outpatient to an inpatient setting, which limited my access to patients. But again, you know, when I realized that there was a Spanish-speaking staff member, you know, I would always get requested to go speak to my patients, you know, whether it be for warfarin education or explaining to them what their disease state was and why they were actually in the hospital. So, you know, as an inpatient intern, not only was there not that much face-to-face, but when I actually did have face-to-face contact with my patients, I was able to actually spend a little bit more time with them because there wasn't that rush of being in an outpatient pharmacy where there's more time constraints. So for pharmacy, next slide, sorry. So for pharmacy school, I knew I wanted to go to University of the Pacific. And it was the only school I had applied to. So I took my chances, and thankfully I got an admission offer. But throughout pharmacy school and even before that, I loved volunteering. And during pharmacy school, I was able to volunteer at some of the clinic events that had higher Latino populations. And it was overwhelming, the gratitude that was shown from this community. And not only did they congratulate myself and the other Latino pharmacy students on becoming pharmacists, but they wanted to know what they could do to help increase the turnout with the community members in order to outreach as many patients as possible. And the services we were providing were cholesterol screenings, blood pressure monitoring, education on good sleep hygiene, and a lot of these younger community members are willing to make these changes, but it's getting the older generation to actually come out and participate. And it's, with this Latino community, the sense of family and togetherness and just being a part of that change feels really great. So during my API rotations, I had the opportunity to work with Dr. Herms Rivas in the diabetes clinic, working with the Spanish-speaking patients, which was amazing. I got to see what it would be like to care for Latinos in my community and the impact that I could potentially have in an ambulatory care setting. I did make sure to tell all my preceptors, of my interests and, helping the Spanish speaking population in whatever disease state it was, psych, inpatient, diabetes, hypertension, anything you could think of, I wanted to be a part of it. And, a lot of the verbiage, don't ever be afraid to say, I don't know how to say that in Spanish, because some of it's not common language, and it's okay to say, hey, I need to go look up some terms before I can have this conversation with a patient. So don't ever feel ashamed. That shouldn't stop you. So for my residency applications and for my tips for success, again, I let all my preceptors know that I was interested at the beginning of the rotation in a residency. And this allowed them to provide me with opportunities to help with quality and process improvement projects, presentations to staff members, patient education. I actually got to help write a chapter of one of the national protocols, which was a great opportunity that I don't think I would have gotten had I not mentioned that I am interested in pursuing a residency. So this was all in addition to, my other assigned projects from those rotations. So don't be afraid to take on extra work, because it pays off. It let them get to know me better. And then that way, when they were writing my letters of recommendation, they could speak more to my work ethic and my ability as a potential resident. In terms of CV content, volunteer work and leadership positions always look great. I volunteered whenever I could, and I was also the president of the Honor Society, and I was a member of a few of the leadership organizations as well. But leadership organizations are great, but leadership positions do not have to be school related. And that's another thing that I think is very important, is that not everything has to be school related. We want to see that you are a person and that you have interests outside of school as well. The best tip I guess I could give is to, get intern experience. I worked every weekend throughout pharmacy school, and, not only did this help solidify the information I was learning during school, but it also helped me to develop more of those soft skills, those people skills that, not everybody has, but everybody can learn. So, you may not have the best grades, but if you can talk to somebody, that far outweighs, the B that you got versus somebody else's A. For the letters of intent, be bold in your letter. Residencies have to read so many letters that you want yours to stand out. And you can do that in the first few sentences. I'm happy to share my letters with anybody if they're interested. But I think that if you look back on all of your IPI and API experiences and look at the, what impacted you the most, I think if you're passionate about what you're doing, it'll come easy. And, that's the hardest part, is actually getting it out. But just, take time to reflect on every experience that you have. It's not a rushed process. So lastly, a little bit about my residency program here at Kaiser Permanente Napa Solano. Not all Kaiser residencies are the same. Mine is an ambulatory care focused residency with an option for an inpatient focus. And my rotations have included chronic pain, psych, trauma, ICU, infectious disease. And I'm currently working in the diabetes clinic where, although I'm not with Dr. Hearns Vivas, I at least get to speak to some Spanish-speaking patients, which is great. Again, you know, there's still phrases that I don't know and that I have to look up, and I'm completely fine with saying, hey, give me a second, I'll be right back. But I have noticed that preceptors, you know, when they find out I do speak Spanish, I still get consults all the time. Hey, I have this patient on the phone who I don't know what she's saying, or they'll send a text message that doesn't exactly translate correctly just because of the writing. And, you know, I'm happy to help, and it feels great because it's just, you know, one of those things where if you can help make somebody's life easier in any language, it's great. But yeah, so if anybody has any questions or, you know, wanted to speak more, I'm more than happy to share my contact information. And, you know, thank you guys for having me.
Thank you, Dr. Stephanie Golick. I will tell you that you have a number of people who are on this call tonight who are connecting with you because they are also first generation students who are becoming pharmacists. And so they're really connecting with your story. Next up, we have Nisha Patel, who will be talking about intern jobs and next step.
Thank you. So we thought this would be best to leave to the end, as now you've heard about Kaiser Permanente and the various things that our leaders do, our managers do. So my job here is to bring people like yourselves into the company and provide those opportunities. Go ahead and move to the next slide. So our focus when you come into Kaiser as an intern is primarily to give you the experience of customer service, like Stephanie was saying, you know, the experience you get speaking to patients. Those are things that you do have to build up. We also go over prescription times and, you know, how quickly you fill things or how quickly you're moving along. Also the expectations as far as attitude, teamwork, attendance. We're giving you all that experience when you're coming in. You will notice at Kaiser that we're very fast paced, as Alfonso had mentioned earlier, but we're a fun group to work with. The tenure here is incredible. You'll see a lot of people here for many, many years. We're a high functioning group. People tend to help out each other a lot here, and we all work together. And everybody leads by an example, including our leaders. We want to make sure that, you know, as a leader, they're doing what we're expecting our employees to do as well. Go ahead and move to the next slide. So our interns, you do gain an in-depth experience, and it's hands-on. And this experience goes beyond your IPPs and APP rotations. You're working in clinics where we have patients coming and you are able to do consultations with them as well, normally as a third or fourth year student. But you do play a key role in the pharmacy with all the team members, the operations team, the KP members, the full healthcare team. Our interns normally do work for us for most of the years that they're in pharmacy school. Next slide. So this is our interns, a lot of them do stay for the 4 years, and they get to experience pretty much all the roles within a pharmacy when they come work with us. Most of our pharmacy interns do start in an outpatient retail type setting, but you do have opportunities sometimes to work in a hospital inpatient setting or an ambulatory care setting as well. You also get access to working with electronic medical records and systems that are integrated. So we have systems that are national, and you get to work with those kind of systems as well. You also get to work with our nurses and our physicians as well, because as Alfonso had mentioned earlier, when members enter into our building, they're actually entering into a quote unquote all-inclusive type of building where you get all your services in one center. You're also part of the KP pharmacy team. So the opportunities you get are endless, and you get to focus on the patient just like everybody else. And the career growth here, as you can see with Stephanie, she's here as our resident, but we do also have, students that have started with us in intern roles that are now actually pharmacy managers and leaders with us. So I feel like when you come to Kaiser, you're not just coming for a job, you're actually coming for a full career. There's so many things you can learn here and explore so many different roles just because we have endless opportunities with us. Go ahead and go to the next slide. So here's where you can actually apply for an intern job, or in the future, you can also apply for staff positions. This is our jobs website. And then we do require that as an intern, you actually have an active California intern license. You guys are all experts at typing, so I don't even have to mention the typing requirement. And then what we request is when you build your profile on the jobs website that go ahead and set alerts so that it will notify you when a job is available so that you can apply right away. So that's about it. Go ahead and go to the next slide. Here's our contacts. So we have Michael Selva, who you can contact for intern opportunities. And then we have Jen Diacuna, who you can actually contact for staff or management positions in the future. I did put on the chat as well. We offer quite a few residency programs, and you can visit our residency site at pharmacyresidency.kp.org. So this is heavy recruitment season for us for residency programs. I do help nationally to recruit for residents. And this year we will be placing a total of 98 residents at Kaiser. So we do have quite a bit of opportunity for all of you that are interested in residency programs. And all of our programs nationally will be exhibiting virtually at ASHP. If you're attending the conference, we will be there as well. Thank you, Lisa.
Great, thank you so much, Nisha Patel. There are lots of questions in regards to internship, and we'll kick it off with this first question since we're talking about internship. One of the questions is for actually all the panelists, would you recommend getting a second internship during pharmacy school for more experience, such as one in the community setting and one in the hospital setting? Thoughts?
Yeah, I can take the first crack at that. If you have an opportunity to intern in an inpatient setting, jump on it. And the reason I say that is those are very difficult internships rotations to get. And I'm talking inpatient in the hospital. Most of are in the other settings. So if you're offered one, if you see an opportunity, I would say take it. You'll find two things. One, you'll get the experience that maybe a lot of other folks don't have. Or two, you'll also figure out, maybe the inpatient setting is not something I want to do, right? Not everyone's cut out to work in the inpatient in the hospital, right? You're not around patients. For the most part, you're in the setting unless you're doing clinical work on the floors. But you'll get some experience on what the setting is like, but also you'll have a unique experience, which a lot of folks may not get the opportunity to do. And we've had pharmacists who want to work in the inpatient setting, but since they never had that experience, it's tough to really get into that setting. So yeah, take the opportunity if it's there for you.
Okay, and as a second-year pharmacy student, what would you recommend to be the best course of action to take to become part of Kaiser Permanente's team? So do you only hire first-year students, or maybe someone more advanced in their student career would have an opportunity?
Alfonso, I'll answer that from what I know. So we do hire students in first year, second year. It just depends on the site and what opening they have, because they can only accommodate a certain amount of students in each year. So for example, if we had all fourth year students and you're all graduating at once, our pharmacy would be in a high need for interns. So we do hire different levels of students. And then most of our students do stay with us for, 2, 3, up to 4 years at times.
Great, and I know some of the APPE and IPPE rotations have been disrupted because of the pandemic. Would this be any risk for disrupting the hiring for interns?
We haven't been told, Alfonso. Anything different you've heard?
No, not for hiring interns. Yeah, or there was early during COVID. Of course, everyone there was a slight pause, but since then it's back to offering those opportunities.
Business as usual.
We're trying.
For now, yeah.
Right. Okay, the next couple of questions are for Dr. Hearns Rivas. Because of the significant difference in diabetes patients between Hispanics and whites and the focus of controlling diabetes specifically within the Latinx population, do you see the percentage of Latinos being diagnosed with diabetes lowering at all in the future?
On the contrary, I see that number going up. I believe that, for example, and specifically to California, so Latino population, it's rising. And the one factor that diabetes educators are looking at right now is pre-diabetes and diabetes in youth. That number is going higher. And I'm also seeing a higher trend of younger and younger patients with diabetes. So for instance, at the beginning, I would see more of patients who are like in their, late 40s, 50s and above. Now I'm seeing patients that are in their 30s, sometimes much younger than that. Of course, the younger group, they tend to be bilingual, so not just monolingual Spanish speaking. So they're more than likely with my English speaking counterpart, APM. So yes, I do see that number rising. And again, with the Latino population rising, those numbers are going to go up. So we need to be ready for once that we have that increase.
Okay, and medication adherence is always a huge problem and can be tricky to overcome. Is there anything that you have done or that you have seen to be effective in your patient experience to help increase patient adherence?
Yes. A couple of things, and I hope that these will help you as well. So one of the things that I find to always be helpful is to just non-judgmentally ask them why. What's keeping you from taking your medications? What issues are you having? Tell me more about that. So let's not jump into making assumptions that they're being dismissive, that they don't care. There's usually something really deep going on. I've come across some very interesting stories. And then oftentimes it's a matter of coaching and helping them figure out creative ways to think outside of the box to increase their adherence. So really, number one, being non-judgmental, and then number two, just ask them why. The patient will tell you, and then explore some alternatives so that they can increase their adherence.
Okay, great. And this is for the entire panel as far as where Kaiser Permanente is moving with their ambulatory care services. One individual is wondering, do you see the ambulatory care practice expanding into the realm of CKD if it has not already?
It's a simple answer, yes. It's a space within our organization that's growing, just like diabetes, and for the entire country. So there is a real need in terms of what can be done early on, and we say CKD, or chronic kidney disease. So they're talking about, right? So you catch them early, and what can be done earlier? A lot of work that Maria is doing now, right? Catch them early, and what you can do, because that disease progresses into the worst case scenario, of course, the dialysis center, right? So we're seeing a higher prevalence of that, and we're trying to figure out where can we, with terms of pharmacists or medications, we can have an effect earlier on. So yes, there is a big need for that. We're still trying to figure out where we can do the most, be the most benefit. But everyone knows it's not a crisis yet, but it's getting pretty close, just like diabetes. Yeah.
Great, thank you so much. Next question is for Michelle Linares. Are there any APPE opportunities with KPLA?
There's always room for opportunities with KPLA. I wanted to start with that. So, at this moment, we're going to lean really on NHPA and other affinity groups to help us identify other opportunities. But I would say that we're always open, and we always lean on where our future workforce and current workforce want to see change. So we want to increase representation, we want to increase experience, we want to make those connections. So that definitely is an opportunity, but we don't have anything at this time. But again, it's an opportunity that we are definitely take to heart and can work closely together to make that happen with the right partners.
Great, thank you. And Nisha, I know that you had offered a response to that, specifically about the APPE rotations.
Correct. So we do at Kaiser offer APP rotations. However, your specific school has to be contracted with Kaiser in order to do that. So we do have a list of schools that are already contracted. If you're at one of these schools, then yeah, you would just work with your coordinator, and they would work with our coordinator, and they would arrange that rotation.
Okay, great. Overall, this is for the entire panel. What would you say the percentage is of Hispanic leaders within Kaiser Permanente in the clinical workforce?
That's very specific. It's clinical leaders, leaders in the clinical workforce. Very, very small, let's be honest, right? There's very few of us. You've probably got the handful who are on this panel now, or probably the majority of them. There's not very many of us, let's be honest. And that's why the work that Michelle is doing, and we're all here trying to motivate you guys on the other side of this, right? To be part of that. That's why we're here. I mean, when California is ready to go to 50% of the population Latino, there should be a reflection of that also in terms of leadership positions within the organization, right? And that's just California, I'm like Texas and everywhere else in the country, right? So there is a big need, folks, and we can't stress this enough that you need to find once you get through pharmacy school, right? There's those opportunities for leadership positions. They're there, and then the one thing I would add is look for those mentors. Now, also, mentors is a big piece to that, and mentors in leadership positions that can really help you out. So,
I also want to add, Kaiser does offer a second-year PGY2 Health System Administration and Management residency. So we're also offering that. I know I've talked to Stephanie at length about it, encouraging her to apply. But that is a residency that we're offering that's very, very successful. It's out of Southern California, and every one of our students got placed in a management position. So please check that out as well.
It's really great to know. Thank you so much. And Dr. Becerra, I completely agree with you. We need more of us out there in leadership roles, whether it's with Kaiser Permanente or with another organization. And just
right.
as Dr. Hearns Rivas mentioned, that being culturally sensitive and connecting with your patient on that level of also being Hispanic not only will improve diabetes, but it's going to improve the entire spectrum of healthcare issues that our Hispanic populations are facing. So we are at time right now. If there's any additional questions, we'll make sure to try and connect with you individually. But I will have a request for our Kaiser Permanente leadership. Dr. Becerra, you had presented the 6 forces as far as changing or shaping healthcare in the future. I would like to say that there's going to be a 7th force, and that's going to be the Latinx leaders that are coming out of NHPA. So if you don't mind making that small modification to that slide, we'd appreciate it.
Will do.
Okay, thank you so much, everyone, and have a great night. Thank you so much for joining us.
Thank you. Good luck, everyone.
Thank you.
Thank you.
Gracias.